So we can go ahead and get started.
I know.
So I'm really excited to have everyone here today. This is the second seminar of our fall speaker series. Just by way of a preview before I introduce Dr. Fillmore, our final speaker will be after Thanksgiving in November, Dr. Molly Monig from Brown University. Her work intersects neuroimaging, neuroendocrinology, and also looking at aging as well with respect to alcohol misuse and opioid misuse. So she'll be coming to give a talk on her research. I'm not exactly sure what part of that she's going to talk about because she does so many exciting things. So there'll be she's also early career as well. She's currently an assistant professor. So I think that'll be helpful for some of our trainees to get a chance to meet with somebody who is, still trying to get their lab really up and running and secure funding. So that'll be really exciting. Not that it's not valuable to hear from people like Mark, but even he and I talked yesterday about it's good to kind of get exposed to the full career spectrum. Somebody who's had several R01s and a very productive and prolific career, and then someone who is, as he said, kind of trying to get grants now and what the climate is like for current times. So stay tuned for an update on that and when that'll be happening. But I have the pleasure today to introduce Dr. Mark Fillmore. He's a university research professor at the University of Kentucky. He received a PhD from the University of Waterloo in Ontario, Canada. And he's authored over 150 peer-reviewed articles in the areas of alcohol misuse from a sort of behavioral pharmacology, human laboratory, and clinical trial perspective. His research focuses on kind of the intersection between behavioral disinhibition, acute alcohol effects, a lot of work in the area of driving. That's kind of where I really became familiar with Dr. Fillmore's work. Very carefully controlled laboratory studies with alcohol administration, looking at driving performance. And so he's been funded consistently by NIAAA. And I think what's really exciting is that he also maintains a very prolific lab from the standpoint of training. So a lot of the articles that you might read in the area of inhibition and alcohol have his fingerprints on them as former trainees and former mentees from his lab. And I've met several of them through my career as well. So without saying too much more about that, I'm really happy to introduce Dr. Fillmore. He's going to be talking about reinforcing and disinhibiting effects of alcohol, as well as some exciting research on the impact of the menstrual cycle on these topics as well. So please join me in welcoming Dr. Fillmore.
Thank you, Michael. I just got into page up, page down.
I was trying to find what else.
Oh.
So, up and down the mouse.
Up and down, I must. Good morning. Thank you for being here, and I really want to thank everybody for inviting me. It's a real honor to come to an institution like this and be invited to give a talk. And I've really enjoyed my time here, speaking with everybody and getting to learn what you all do. It's quite an enterprise that you have going on. And as I say, yeah, I'm honored to be here, and I hope I can say something of interest in the next hour that would be of some interest and some value to you. So as Michael said, I study the acute effects of alcohol. My general interests are in alcohol addiction, substance abuse, and yes, cognitive mental impairments, and I'm interested in the acute and the chronic effects. But the reason why I'm at that sort of interest is that the acute sensitivity to alcohol for me is something that I think about as a marker or maybe a causal factor that can lead individuals to develop alcohol use problems. And alcohol use disorders, it's an individual difference problem. Most of us in Western society are exposed to alcohol, and only very few of us develop problems with it. And so my job really has been to try to understand why. And for me, it might be my basic general, very general working theory that some people react differently to alcohol, causing them to drink more and perhaps move on and develop dependence. And that's basically the theme of this talk. And I'll tell you a little bit about how we examine how they react differently to alcohol. So the types of reactions that I'm interested in then, heightened subjective rewarding effects. Not surprising, if a drug has rewarding effects, it probably has some type of abuse potential. But for me also is the heightened impairments in cognitive function. And as Michael said, I'm interested in disinhibition and inhibitory control. So how did the degree to which alcohol impairs inhibitory control? Is that a factor that can contribute to its abuse potential? So inhibitory control is important because of the ability to suppress or delay responses to immediate stimuli. It enhances our behavioral repertoire of what we're going to do with that stimuli if we can stop and not have to react to it immediately. Why is that relevant to alcohol? The idea that if you cannot inhibit responding to a stimulus, maybe taking the drink that's put in front of you, you might be more at the mercy of that environment. And if that environment is nothing but cues to drink, then you will react to those types of cues. So it could, impair your ability to terminate ongoing behavior. And the binge drinking, you could sort of envision that as just perseverative responding, continually taking alcohol. So the working theory then is some individuals have strong impulse control when sober, but little control after a few drinks. This is not a new idea. This is a completely stolen idea from the past, from the 1950s, from Jelinek, who talked about different types of alcoholics when he was developing his disease conception of alcoholism. And he had two major types of alcoholics. He had the delta alcoholics. That's the constant daily drinking. They can control the quantities within drinking occasions. No real social problems. They function well. They can hold it together. Then they can maintain a job. And it's not your typical AA member. Now, they're likely dependent. That's why they're drinking a little bit throughout each day. And they likely have a bottle of booze in the desk drawer. So the gamma alcoholic, though, is the individual that suffers intermittent bouts of heavy drinking. And for Jelinek, he talks about it as a loss of control. They cannot control the quantities. They might have an intent to drink one or two drinks, but once they drink that one or two drinks, they have a loss of control where they cannot stop consuming alcohol in that episode, and it leads to a serious binge episode where they drink to a point of gross intoxication. This is the AA recognized type of alcoholism. One drink, one drunk. There's dozens of slogans that they have for that in AA. So the extreme view then is, this is Jelinek's definition of loss of control, just so you can sort of see where we're coming from. This is a stage of drinking history when the ingestion of one alcoholic drink sets up a chain reaction, so they are unable to adhere to the intention to have one or two drinks only. The process goes on and on until the drinker either cannot ingest more alcohol or the drinking is stopped through extraneous circumstances, end up in jail or something, pass out. So that's an extreme view of loss of control that people still argue about. Today, we have many of us have a more tempered view of loss of control, where it's not likely to lead to this gross intoxication where you drink or you pass out and it's inevitable. But people talk about maybe you have impaired or reduced inhibition in response to alcohol that can sometimes increase the amount that you drink to more than you initially intended to. Doesn't have to be an all-out binge and a complete loss of any type of control. And so that's kind of the model that I work with in terms of a working hypothesis. And so on the one end, you've got the increased reward. And this is the alcohol will have some rewarding properties that could lead to increased consumption or binge drinking. But also alcohol can reduce your inhibition to stop ongoing behaviors like taking the next drink. And that could also maybe increase consumption. So we think about addictive drugs in terms of rewarding properties quite often. That's their traditional view, that they're reinforcing because they make you feel good. And the feel good part, the increased rewarding effects of drugs, not just alcohol, but other drugs, is a traditional treatment target with drugs like naltrexone, for example, to try to reduce some of the rewarding properties of opiates. So that's just kind of how I see the world. And in terms of studying it, I have to be able to measure someone's inhibitory control. And many years ago, I developed this task, or I actually modified it. I didn't develop it. I stole it, then I modified it. So, yeah. I modified it because it looked like it had a good pre-potent responding cue. And I just looked at the face validity of it and I thought, I bet you people have difficulty stopping a response when they're intoxicated in this task. And so you basically see a rectangle, like on the left side, you just see this white rectangle lying flat. And in this case, it's a go cue, because in a second later after displaying it on the screen, 80% of the time it'll turn green. And your job is press a key if it turns green as fast as possible. If it turns blue, don't press anything. And so after you see this, these cues, 80% of the time, it's turning green. That flat bar is basically it's a go cue. It's likely, hey, that thing's gonna turn green. If the bar stands up tall in this example, 80% of the time it turns blue and you don't have to do anything. So that starts to function as a no-go cue. The trick for people is when you have this go cue, being able to stop on the rare occasion when you suddenly have this no-go target. This is what becomes difficult under alcohol. When you're sober, you can still do it. It's harder because you're primed to respond. But under alcohol, that's the challenging condition. Stopping when you didn't expect that you would suddenly have to do that. So the task basically works with, we have a fixation point. Things move pretty rapidly. They do a couple of hundred of these trials. The cue comes up, it turns green. You press a key as fast as you can. It tells you your milliseconds and you're off and running. So that's our task. It's of interest because these types of measures show neural activation that corresponds with it in key brain areas that we know are important for inhibition and for the general control of behavior, such as the anterior cingulate. It's involved in error monitoring, conflict resolution, and the right lateral prefrontal cortex. That exerts some top-down influences on goal maintenance. And we know that these brain areas are very active when people are trying to suppress inappropriate actions on tasks like this. So in terms of the studies I'm going to talk about that use this measure, I've just laid out some general study characteristics so you can have a sense of the population, the amount of alcohol that's being administered. We use male and female adults. They're usually they're non-alcohol dependent. They haven't been in alcohol treatment, except for DUI offenders, but that's a whole other set of studies. But these are basically healthy young adults from 21 to 35 years old of age. These sample sizes that you're going to see, they could be anywhere from 10 to 40 subjects in these groups. We take a lot of background measures on their alcohol use and their other drug use history. The doses of alcohol that we administer are pretty moderate in that we give doses, say 0.65, 0.6 grams per kilogram, producing blood alcohol concentrations of anywhere from 50 to 90 milligrams per deciliter. And we always have a placebo control type of condition as well in these studies. And yes, our alcohol is ever clear. And I think another type that we use when we can't get that to their identical alcohol concentrations is, I think it's called Clear Spring. This really nasty grain alcohol. They're all about giving it a clear name and something about nature. There's nothing Clear Spring about the alcohol that we give. So, but it is cheap. And it's mixed with, okay, you know, the big K is for Kroger. If you're from Kentucky, you know, right? So it's cheap alcohol and cheap mix. So we keep it all matched up. The blood alcohol curves that we produce kind of look like this. We'll give basically a bolus dose of alcohol in the studies I'm going to talk about today. So because we want a quick onset of effects. So the BAC will rise quickly upon drinking. Within about an hour into it, they are at a peak, and then you'll have a slow decline after that. So what I want to talk about, you know, with all of that in mind is some of the early data that we got first, where we looked at impaired inhibition as maybe a mechanism of this abuse potential. And this is the idea that, you know, this alcohol produces a disinhibition. It can impair your inhibitory control. And maybe that impairment of your inhibitory control somehow can contribute to how much you tend to drink, whether or not you drink a lot or a little. So we're looking at the acute effects of the disinhibiting effects of alcohol in relation to the amount that you might consume if you're just given alcohol and you can freely consume it. So in this first session, this is the controlled dose of alcohol. These are inhibition failures on the left. More inhibition failures, it's that more times that you fail to suppress your response when that go cue suddenly turned blue. And so you can see that under alcohol, 0.65 grams of alcohol, the inhibition failures are higher than for individuals than when they were tested on a different day in response to a placebo. And these are sort of counterbalance sessions as well. On the right side, we just keep track of speed of activation. And on this task, it's not really some kind of trade-off, like alcohol makes you respond more quickly and that's why you fail to inhibit. If anything, alcohol, of course, would slow your reaction time down a little bit. And sometimes it's not even significant. And there's just a very, very mild slowing effect of alcohol on this task. So the bigger effects that we always see with alcohol on this task are with the inhibitory failures. So you have good evidence that this dose is producing a pretty robust increase in inhibitory failures on the task. So then the next phase is we've tested them through this group of individuals under alcohol, under placebo. We show that alcohol impairs their inhibitory control. Then we let them come in for a third time and they can just drink as much as they want. We make it sort of a beer tasting task. So this study would focus mostly on individuals, focused only on individuals that liked beer because we were going to give them beer. And so in a taste rating task, you have individuals that we just have them come in and we say, okay, we're going to have about 5 different types of beer. We want you to rate them in terms of how much you like them. And you can drink as much or as little as you want. You can watch TV, do whatever you want to do. And what we're, of course, interested in is how much do they drink in these tastes, right? And we have different brands and they're real beers and they're all about 4.8% alcohol. And we measure how much they drink in the end. And they've got lots of time to drink. There's no constraints on any of it. So because it's tough to get them to drink in a lab anyway. I mean, I love your lab your bar upstairs. It's much better than what we have. So you do want to make sure that they understand that no matter how much they drink or how little they drink, they're still here for about 3 hours. Right, that kind of thing. Right. So we put those types of considerations into these types of designs. And so the basic question then is do drinkers who suffer greater impairment of inhibitory control when they got that control dose, do they tend to drink more? And so we get some evidence, some correlational evidence. So that's, I was looking at the wrong one. Actually, I think that's one of our lab techs posing as a subject, grin on his face. And we've got the beers and they're coming out of the fridge and they're trying things and they're filling out the paperwork and telling us how much they like them and what attributes they like, all data that we never looked at. They did a good job though. They filled out those forms. So then we get this relationship. So this is the degree of impairment plotted along the bottom with just greater impairment coming off to the right, and then the amount of alcohol that they consume. And you can see that these drinkers drank anything from very little amounts of alcohol to almost nothing, all the way up to 1,500, so 1.5 liters of it. So pretty much everything that was available to them. And you get this general positive relationship. It's not striking, but it's a significant positive relationship that shows that those that were more impaired, their inhibitory control was more impaired in response to the control dose, came back to us and they drank more alcohol. So it's perhaps then that there's a propensity for this heavy drinking to be linked to the intensity of the disinhibiting effects that are experienced by alcohol. We've replicated this in several studies. Again, it's not like all the points line up on a tight regression line. There's still lots of individual differences. But these two findings for me made me kind of interested in this. And then a lot of people of other labs started widely using this task as well. And it seems to be pretty good at detecting acute effects and indicating maybe the potential for abuse in people that tend to show larger levels of disinhibition on the task. So with that kind of launched us into different directions of what we can do with this measure over time. And one of the questions that popped up that was of interest to us about 10 years ago was studying the alcohol effects in at-risk populations, such as young adults with attention deficit hyperactivity disorder, ADHD. So we know that substance use disorders are common among adults with ADHD, about 22% often report substance use disorders. We know that poor impulse control and poor attention is characteristic, and it may be a contributing factor to the risk for developing alcohol use disorders or problems with drinking. So we became very interested in, well, how are those with ADHD affected by alcohol? What is their sensitivity to the disinhibiting effects of alcohol? After all, they're supposed to have sort of impaired impulse control. Maybe they're more sensitive to the disinhibiting effects. They might also be more sensitive to the rewarding effects as well. So we're kind of just taking a look at both pathways with this population as we began to study them. So the general methods for these experiments were kind of the same in terms of screening, but we used adults with ADHD and we compared those to comparison controls. The young adults with ADHD, they had to have a childhood or a current diagnosis. They had to be on stimulant medication, and that was important for us because you can't just have a childhood diagnosis and now you're 23 and you've been asymptomatic for like 10 years or 8 years or something. It had to be severe enough that, you know, you're likely a college student, you're 20-some years old, and you're still taking medication to do your exams and that because you still have symptoms. So that was important. But when we bring them in the lab to pit the effects in our favor, we tested them off medication because we want to see these effects of alcohol, not see them being offset by medication. But that would be fascinating to be able to do that. So they tested off meds, and the research question for us is that, do these individuals with ADHD show greater disinhibition following a dose of alcohol compared with a non-clinical group? So simple first question right out of the gate. And what you have is, this is the no-go cue condition, proportion of inhibitory fails. We gave these people 3 different doses, placebo, 0.45 and 0.65 grams per kilogram along the bottom. So you kind of get a little bit of a dose response thing going. But let me just show you the dark bars, the lower bars. These are our control subjects. So inhibitory failures go up a bit from placebo to 0.45 grams and up just a little bit more when we kick them up to about 0.65 grams on that particular dose day. But you see the young adults with ADHD, they have higher inhibitory failures at all conditions. From placebo, they show a pretty robust increase too, from placebo to the intermediate dose, which is 0.45 grams. And then not much more after that. They just sort of hit this high level. And a 30% failure rate is quite high. That's kind of where they peaked out. So we have some pretty good evidence that this is sensitive to ADHD and perhaps an increased sensitivity of ADHD, young adults with ADHD, to the disinhibiting effects of alcohol. So looking at this a bit more, we want to then just shift gears and talk about, okay, well, what about attention to alcohol as a risk factor? We pay attention because, you know, this is part of ADHD, is it's an attentional deficit, and we tend to pay attention to things that we want or things that we like. And so one of the indicators of motivation and incentive to drink is, do we have an intentional bias to alcohol over, say, non-alcohol beverages or cues in the environment? Do we look at alcohol in the environment for longer periods of time? And this is a common measure, just straight up called attentional bias to alcohol. And so we have these measures as well in the lab to look at it. And it's basically, you're thinking about it as maybe you're anticipating the rewarding effects. And so a lot of people have been measuring this for some time, and I'll walk you through how we do it. We use eye tracking equipment, very overly priced, very finicky eye tracking equipment. And so this is another one of my graduate students sitting in front of the eye tracking device. There's cameras inside the monitor looking back and locked onto your eyeballs. And so they know exactly where you're looking on the screen, pixel by pixel. And you'll see 2 images come up on the screen. There's this is a bottle of soda, and then there's a bottle of alcohol on the left. And so what we're interested in is looking at the gaze time. How long do you keep looking at each of these images? So in sort of a bigger, that's the sort of the blow up view. And it's like, okay, well, you'll look at these and you'll look at this slide. We'll put it up for about 3 seconds and we'll get an idea of how long you looked at Captain Morgan versus Mountain Dew. And then we go on with another slide and we're moving the alcohol from different sides and so forth. Why are you looking at these in the first place? Well, because they'll disappear and there'll be an X behind one side or the other, and then you have to press a key that corresponds to where the X was. So it's basically, it's a reaction time game as far as you're concerned. But we don't really care about that part. We care about which objects did you look at most before they suddenly disappeared every time. So, and what the system can do is pretty good. It can measure with milliseconds, aggregate the amount of milliseconds of total dwell time on an object. And then it can illustrate it in different ways. This is a heat map. And so it just shows like they looked at this one for about if it was left up long enough, 4.48 seconds. Basically, somebody's eyeballs just burned a hole in Captain Morgan, right? Over versus the Mountain Dew. And these heat maps are kind of useful for just showing how we typically look at alcohol in the environment. This is just a group of people drinking and somebody's looking at them. This is what a person without much attentional bias to alcohol would normally do. We look at people's faces. That's what we do. Humans look at faces. And so this is a person looking at this image and they're looking at the eyes all the way through there, right? This is a person with attentional bias to alcohol. Not so much looking at the faces, looking at these drinks that she's holding. And you would get a sense that this person's more interested in alcohol than people, but to put it, kind of bluntly, I guess. But so that's how this task works. In addition to that, we also measure attentional bias, where we have a freely moving ambulatory subject. Again, another really overpriced piece of equipment is eye tracking portable goggles, glasses. You put these on, you have a camera in the front that's showing you the view that the person is seeing, but you also have two cameras that are pointed back to the pupils of the subject. And then with some math and some setup, you know exactly what they're looking at as they walk around. Of course, you need to power this device, so you wear a dull clip battery pack. You can walk around, and then at the end, we download your data and we see everything that you looked at as you walked down the halls or went outside and so forth, right? A total invasion of your privacy. I mean, if you didn't know you were wearing them, but that's what we do with this stuff. And so we've had experiments where they can just walk into rooms and look around at things, and how often do they look at alcohol. And this one, I don't know, it's kind of a contrived, weirdly placed bottle of Budweiser up there. Why is that there? That's odd. But then in fairness, it's like, okay, well, put the Dr. Pepper by it too. So, there's two odd things. What do you look at, right? One of the things we've learned from the glasses, more than anything else, and again, we paid too much for the equipment to learn this, is that, yeah, you'll look at a lot of new stuff. When you walk into a room and everything's novel, you give everything a lot of attention. And so there's novel bottles of booze, but there's the other novel things in the room. So nothing really alcohol doesn't really get attentional bias when everything is new. Everything's got the bias. But then when you repeatedly go into that room over and over again, you stop looking at the other things. And if a person has attentional bias, then they're just left looking at alcohol. And the novelty effects wore off for the other things. And so we learned that, hey, maybe it's difficult to measure novelty or attentional bias to alcohol when everything is novel. So when you first go into a new bar, you'll be looking at everything. You need somebody to go into that bar that they go into 1,000 times before and see, are they just looking for alcohol? Again, it's not the greatest finding, but we managed to publish it. I thought, yeah, we damn well got to publish this thing. We paid $20,000 for this stupid glass, right? So we got that out there. So one of the questions I had, and nobody really ever looked at before, even though many people have studied attentional bias to alcohol and reported that heavy drinkers show more attentional bias, people in alcohol treatment centers show more attentional bias to alcohol. Nobody thought, well, what does alcohol do to attentional bias? And so since we like giving alcohol, that was one of the first questions. It seemed to me that you shouldn't have an attentional bias so much anymore. If we give you alcohol and you're quite intoxicated, what are you looking for it for? You don't need to look for it anymore. We gave it to you, right? And so that was pretty simple of an idea, and that's what the initial data showed. You can see under placebo, you've got an attentional bias score, and these are in millisecond differences. These are very small effects, but robust in terms of being significant. If that makes any sense, I don't know if it does. But yeah, you're talking about, you have a standard attentional bias effect where you're 60 milliseconds longer on alcohol versus neutral. But then we give you some of these doses like 0.45, 0.65, and attentional bias wanes, it starts to go down. And it kind of makes sense. If attentional bias is to alcohol is an indication of motivation because you're anticipating some rewarding drink or something that you want, we give it to you, it should go away. And so it does. So then the question was then, do adults with ADHD show this decline in attentional bias after they drink? And again, the idea is, we don't really know. Their control over their attentional behavior, over their attention, might be impaired, and they might just keep looking at things. So this data looks a little more complicated, but the square boxes, the solid line square boxes at the bottom are control subjects. And you can see that even in placebo, they don't show a lot of attentional bias. And it kind of goes up a little bit when they get, say, 0.32 grams per kilogram of alcohol. That's enough to maybe produce a BAC of 40.04. And then up to about double that to about 0.08, it falls back down. So they just don't show much attentional bias. But our young adults with ADHD showed no attentional bias to alcohol in this sample when given a placebo. But then when they're brought back in, and again, these are all counterbalanced days, so counterbalanced dose orders, when they're brought back in and they're given a mild dose of alcohol, they show a pretty robust increase in attentional bias that still stays somewhat even when we double the dose. So it seems that, you can give them alcohol and just kind of look at it a bit more. And it was quite an interesting finding for us that I'm still not entirely convinced that, I understand it. And I don't mind saying that. The longer I do this, the less I think I understand. So, but this was kind of remarkable as well, though. Then we looked at the individual differences. So this is attentional bias under alcohol. It's a strong predictor of ad lib consumption. We bring all these people back in for another day, right? We've given them 3 controlled doses of alcohol. And on that final day, come on in, we got a taste test for you. Don't forget to fill out that paperwork because it's really important to us. So we've got these young adults here this is our group with ADHD. This is the attentional bias that they showed in response to the intermediate dose of alcohol, the 0.32 gram per kilogram dose, in relation to how much beer they drank. And so these are individuals that showed high levels of attentional bias when given that intermediate dose, and they drank considerably the higher the attentional bias, the more alcohol they drank when given ad lib access. We didn't really get a strong relationship this time with the controls, not as much as the first time. So this kind of struck us as kind of the 2 very different populations in which a little bit of alcohol seems to increase the attentional bias in the young adults with ADHD. We also asked questions too, directly. Of course, you can measure the subjective effect of alcohol just with Likert type scales, visual analog scales. And this is kind of basically how we would ask them to answer these questions. And today we use slides on computers where you just slide to the level that you want. And you're just indicating the intensity of a variety of effects like intoxication. And so when we look at 2 effects here, this is in this sample of young adults with ADHD, we can look at intoxication ratings, and then we can also ask them questions about, well, do you think you're even able to drive? And so the dark squares are the controls, the open squares are the young adults with ADHD, and we have our intoxication ratings as a function of placebo, 0.45, 0.65, and we see that the intoxication ratings in the controls just go up in a very orderly manner. They're just, the more they drink, the more intoxicated they feel. But for the young adults with ADHD, we've got, it goes up quite a bit for the first dose, but then when we go from 0.45 to 0.65, there's not much of an increase for that second dose beyond what we see for 0.45. The other thing that we also see, and we've seen this repeatedly with adults with ADHD, they tend to rate their performance as superior to controls. Even in cognitive performance, their performance in driving in a simulator. And so this is a question that says, rate your ability to drive at this time, with your BAC being about 0.05 and your BAC about 0.08. So they're just telling us how much or how well they think they can drive. And of course, you get a pretty good dose effect. You think you're able to drive under placebo, then it goes down with these doses. But ADHD, the subjects with ADHD tend to think that they're better able to drive than controls. And they report this repeatedly over and over in various types of studies. And one of my colleagues who is a clinical psychologist who studies ADHD, mostly with young children, said, yes, there's this bias where they have this positive bias about how well they're functioning. And they see their performance, they don't see any problems with their performance. They think that their homework assignments are fine, that their performance on cognitive exams are really good. They overrate everything. And he's like, maybe that's what you're showing here. They're overrating their performance under alcohol, which could be kind of hazardous and dangerous. So then in terms of perhaps their unique reactions to alcohol, these young adults with ADHD, that they appear to do have different responses to alcohol. They seem to be more disinhibited by alcohol. They seem to be more disinhibited in general as well. They're more attracted to alcohol-related stimuli, especially after drinking, even like low doses. They seem to be primed by it. And they perceive themselves as just overall less intoxicated, less impaired than other people. And so this is the sort of a whole cluster of things that we found over a number of years using this model of how does alcohol affect how much you like it, the rewarding properties, how much does alcohol impair the disinhibiting properties. So I want to wrap up today with the current work that we're doing that again follows the same model, but to a new problem. And that is basically looking at some evidence that changes in ovarian hormones can also alter alcohol consumption in women. And why might that be? And it'll take us back to maybe alcohol and ovarian hormones may interact to determine how much disinhibition we see under alcohol, how much rewarding effects that we see under alcohol. So, but the story kind of falls out from some of the preclinical evidence and a mixture of mixing with some of the clinical evidence that set us up to examine this question. And so for a long time, we see these reports that women are disproportionately affected by alcohol consumption. There's greater risk of organ damage, greater relapse rate, and possibly greater sensitivity to some of the acute behavioral effects, although it's really mixed. And there's not a lot of reports, but I've listed a few where they did find that women had greater impairment on certain types of cognitive tasks. Well, estradiol, ovarian hormone, is implicated in some of these outcomes. So in preclinical studies of rats, we see that there's increased consumption associated with elevated E2, for example. Rats that are in estrus will drink more. And then if you do an ovariectomized animals, if you have those, you can reduce the increased consumption back down to normal levels or down to levels of what male rats would consume. So in clinical studies that's related to this, women report greater alcohol use. They sometimes have reported greater craving and subjective effects during the follicular phase of the menstrual cycle when E2 is rising at that point. And these are types of calendar studies where women are home, they take, and they're not taking birth control, and they're premenopausal, not taking birth control, so they're having a naturally changing cycle throughout the month. They take salivary tests to measure their hormones on daily levels, and at specific times during the day, in the morning and the evening, they report on how much they drank that day. Do they have any craving for alcohol throughout the day and so forth? So there's a lot of detailed measures that are going on over this period of time in relation to those salivary tests, which are all important for us getting back and looking at, well, how high was E2 on these types of given days. And so that's kind of the state of where the research was before we put together this grant to study this in a laboratory model. So women report greater alcohol use and craving subjective effects when they're doing this type of daily reporting, particularly when E2 is rising. Elevated E2 levels, if you look at the literature, are also seem to be associated with greater impulsivity and disinhibition. There's a few studies I looked at where they were using tasks, so like stop signal tasks and other measures of inhibitory control, and pointed out that, the performance on these tasks is a little poorer when E2 levels is elevated. So is there a potential mechanism for this? We know that E2 and alcohol, they share some common neurotransmission targets, glutamatergic, GABAergic, dopaminergic receptors. It's complicated. It's not clear. But the evidence on behavior from animals and from the clinical studies suggests that maybe there's something there, even if we don't really know what the mechanism is. So it seemed like enough for us to go ahead and ask this question and try to get a grant to support this type of research. So we have, our question is, does elevated E2 increase the sensitivity to the disinhibiting and the rewarding effects of alcohol? So it was my clinical associate, Michelle Martel, came to me with that daily recorded data, the calendar data, and the salivary test, and she was doing really good work with that, and said, you know, so I don't know why they drink more or why they say they crave it more. And I thought, well, why don't we bring them in and see if they really do like it more when E2 is elevated? And why don't we see what else, how else they respond to alcohol when E2 is elevated? So the goal would be that we would bring them in and they weren't just telling us how much they drank, they were actually reporting in a controlled study different effects based on E2. So the study design was really looking at women that were 21, 29 years of age, social drinkers, not taking any hormonal medication. In other words, basically no contraception. So they had menstrual cycles that were unaltered by any types of medication. And this is kind of what it looked like. This is the basically you're looking at the solid line is estradiol levels, and you're looking at everything starting out at the beginning of the menstrual cycle as very low. So we've got estradiol, we've got progesterone, we've got the luteinizing hormone, which is the smallest dash. And then everything begins to, well, not everything, but estradiol begins to rise rapidly early in the late follicular phase near the point where there's ovulation. We also have ovulation tests that women do that take at home as well. So we know the particular days in which ovulation is likely happening as well. And it's coinciding with an elevation in E2. I also know, of course, you know, it's coinciding with a very rapid sudden rise in the luteinizing hormone too. So it's pretty hard to get E2 all by itself without another hormone level becoming involved in there and potentially confounding the interpretations of the data as well. But that's what we have in terms of that. And then things begin to come back down again. The point in which E2 and estradiol and progesterone are most discrepant is at that ovulation stage. And they kind of get a little more confused later on. But in terms of our study design then, we decided we would pick these two periods. Our intake session would just be, you know, they come into the study, we get a bunch of background information on them. And we make sure that, you know, they're at the point where they believe that they're starting their period and then they're working forward. Then we would do session one. And in session one, we do session one when all hormone levels are low. So we call this the early follicular phase. And in session one, we would give them a placebo. We would look at disinhibition. We would look at subjective effects. And then a little bit later in the session, we would give them an active dose and repeat the same measures. Session two, when estradiol is high, would occur at about day 13, 14. They would report that they're ovulating at this point. They would come into the session and we would just do the exact same thing again. Placebo, disinhibition, subjective effects, and repeat it again. Now, to prevent some type of weird order effect that we might see, sometimes people's first session would be here. And then they would finish the menstrual cycle, come back in, and their second session would be over there. Just so that we didn't have any type of specific type of order effect within that time period. So that's it. Pretty simple study on paper. Kind of a bear. It's a lot of monitoring and making sure that they're coming in and staying in contact. Things that I wasn't part of, you know, all that daily contact with people, but it's good to have a good team that's dedicated to it, and we certainly do. So one of the things that I thought that would be important just to understand too is there a difference in the blood alcohol concentrations that we get from this dose, depending on whether the subjects are in their late follicular phase or early follicular phase? And no, the curves are pretty much overlying. It's about the same thing. The dose that these women got, by the way, was 0.6 grams. And for just a population of women who get higher VACs than men at a given body weight, that will produce a peak VAC of about 0.08 or 80 milligrams per deciliter, and that's what we got. The hormone levels during our test days for the early phase, yeah, we had a significant increase from early to late phase in estradiol. And we also had a significant increase, of course, in progesterone because that's coming up fast. And we had, well, almost a significant difference. There's a lot of noise in the luteinizing hormone data, but everything's kind of rising at the same time. So again, keep in mind, it's pretty hard to attribute this just to estradiol. So then we looked at their inhibitory failures on the task in response to placebo and in response to alcohol at the early phase, which is the dashed lines, and the late follicular phase, which is the solid line. So under placebo, you have very low levels of inhibitory control. And what's kind of just beautifully lucky is they're identical under placebo at the early phase and late phase, same level of inhibitory control. Alcohol, of course, increases the failures on the task, but we see a much steeper increase of response to this dose at the late follicular phase than at the early phase. And so we get this nice interaction where in the late phase, alcohol increases the failures of inhibitory control by 3.8 times, whereas in the early phase, you only get an increase of 2.7 times. So we get this nice interaction that just doesn't show any difference when they're sober or when it's under placebo. So ask them a lot of questions too under these doses about how they're feeling, what effects are they experiencing, do they like the effects of alcohol. These graphs are a little funny looking because the first two data points are in that session when they got placebo, and then the time periods are after the active dose, 30 minutes after alcohol, 50 and so forth as we go up. The data just show, yeah, they like alcohol, they feel intoxicated by alcohol, and whether they're in the early or late phase didn't matter. They were the same effects. These are a couple more that show sedation, stimulation. It didn't differ. Their self-reported effects from alcohol didn't differ as a function of the follicular phase. So the last bit of data I wanted to switch over to was back to our attentional bias task. And we were interested then, of course, in, well, they're not saying they like it more, but maybe they have a greater attentional bias. And the evidence does show, yes, they do have greater attentional bias. The differences are right here with the little red arrows. So in the early phase under placebo, there's not much attentional bias. In the early follicular phase, when they're given alcohol, they show some increase in their attentional bias, which is interesting. But in the late phase, the attentional bias is just much bigger regardless of whether or not they even got alcohol. You basically have an effect of the follicular phase on attentional bias that doesn't really even interact with alcohol. And so you might interpret those data as that maybe they don't say it, they don't verbally express it, but they are a little more attracted to alcohol cues in the late follicular phase, regardless of whether or not they drank. They're just more attracted to alcohol cues. If you accept that the attentional bias is a measure of motivation or attraction to alcohol. The desire to drink when they were given alcohol, it diminishes, and it diminishes similarly, regardless of whether or not it's early or late phase. So the phase effects really just seem to be specific to disinhibition and attentional bias. It didn't change how people were self-reporting how they were feeling under alcohol. So the implications of this, well, I think, yeah, there's evidence that maybe the disinhibiting effect of alcohol is exacerbated during the late follicular phase. There also seems to be increased attentional bias during that late phase, regardless of whether they drank. So it's when they're sober and intoxicated. And then subjectively, what they're self-reporting, the subjects may not perceive any increased sensitivity. They may not perceive that they're more attracted to alcohol or that they're more disinhibited. Then the implications, I don't know. Talk about, there could be an increased likelihood of women engaging in a binge episode during the late phase. That's what people are saying. They're saying they tend to drink more in the late phase, at least they're self-reporting. Well, it might be because they're more disinhibited when they have a few drinks. And it might also be that they're kind of attracted to alcohol cues a bit more in that late phase. So they're likely to start a drinking episode as well, and then succumb to more disinhibition when they get going with it. What that could mean, well, maybe women that are seeking to limit or abstain from alcohol, they might be more susceptible to sort of violating any types of self-imposed limits. I'm only having 2 drinks, or I'm not drinking tonight. They might be more likely to violate those maybe during the late follicular phase. But I don't know. That's just what I'm thinking. So if you wanted to try to find a sort of a clinical implication of it. So the big pictures, I'm just wrapping up with sort of the big picture clinical implications of the whole set of studies, is that when you go back to this controlled and moderate drinking as a treatment goal, like I said, it's been long debated, and since the times of Jelinek and the loss of control model. It does seem, I think that there's some merit to the idea that the heightened sensitivity to a disinhibiting effect of alcohol could make controlling your drinking a little more difficult, if that's your goal. Maybe you don't want to drink at all then, if you seem to have a problem after a few drinks, stopping the ongoing consumption of alcohol. But we talk about, well, if these are really causal attributes, heightened sensitivity to disinhibition, heightened attentional bias to alcohol, couldn't these be treatment targets? And couldn't you have behavioral treatments to improve inhibitory control and reduce attentional bias? And for a while, that was a very exciting idea, and everybody was looking at this. And there was some laboratory evidence for efficacy of this, but it really fails to generalize outside the lab. There's a lot of studies, well, not a lot, but there's a few studies that they train you to not look at alcohol. They'll train you to look at the neutral objects, and then they'll see, now that you leave the lab, do you drink less alcohol? No. I mean, because they trained you to do something on a task that just doesn't generalize as soon as you walk out the door. Same thing with training your inhibitory control on a task to stop from pressing a button. That doesn't stop you from taking the next drink in the bar. There's a real generalization leap there that the people were going for, and it just doesn't show. So, got to credit them for trying them. So you could train people to recognize these vulnerabilities, though. I mean, you could point these out. I mean, we're now doing studies with DUI offenders where we're trying to get them to understand that they have no idea how intoxicated they are. They need to know, hey, this is your BAC right now, and this is how badly you did on this test. And you're giving us reports that suggest that you might have ADHD because you think that you're really good at this task and you're terrible at it, right? So, so we've got that as a possibility that these are targets or effects of alcohol that they need to better recognize as something that could make them more vulnerable to sort of uncontrolled drinking. So training them to use these sort of external rather than interoceptive cues to estimate their impairment. If they're really bad at estimating their impairment, it may be important to understand exactly what their blood alcohol concentration is after a few drinks. And that information, I think, is good for anybody. It's possible we could hone in on neural targets, these things, the dorsolateral prefrontal cortex, the singular gyrus, hone in on these as neural targets for pharmacotherapy. I am now doing a pilot study with a colleague where we are using transcranial magnetic stimulation of the dorsolateral prefrontal cortex to try to block the disinhibiting effects of alcohol. That should be fun. So I think my graduate students are terrified of the TMS device, but they'll get used to it. We'll get through this together. So it's possible. So that's kind of in a sort of sweep, kind of how I've taken 2 measures, disinhibition and rewarding effects, and have studied them sort of in different populations and in different questions regarding alcohol throughout the years, throughout these past several years. And I've mentioned some names along the way. I've had a great set of collaborators with some of these projects that brought in much needed expertise that I certainly don't have. I also have, over the years, I've probably forgotten a few names, but they're not watching this talk anyway. But I've had a great team of graduate students that have sort of kept my ambition and enthusiasm alive over the years as they've got into the trenches and conducted these studies and did a great job at writing up the results as well. And I've got a current team of graduate students, Annie Griffith, who's working on the estradiol project right now and doing a great job with that. And I've got Sarah and Will as well. And so, and a good round of support from NIH and some other agencies. So thank you for listening, and I welcome any questions. Maybe I've got answers. I don't know.
I was thinking during your talks that latter segment of the things that you're doing with the estradiol is really interesting. And one of the things that, if I remember this right, I think with rats, and this is with other mammals too, is that during estrus, food intake drops, and particularly carbohydrate drops. And to compensate, rats will shift their intake to fat because it's your metabolism doesn't drop, just the food preference drops.
Yeah.
And so during diestrus, there's actually more consumption of carbohydrates and just less consumption and a shift to other foods. And so I'm wondering if there's actually, because alcohol's got a fair caloric load, is that it might just be an acceptance of other forms of high calorie intake during estrus because carbohydrates drop, carbohydrate intake drops.
Yeah, I think that's a really good point, and a very good possibility. This is where alcohol is weird, right? It's a food. It has caloric value. And that could be the motivation to use it when when you're hungry as well, right? When you're low on calories. So yeah, that could be a key factor in it.
It makes me think of your attentional task, instead of doing like alcohol versus soda, you could do like ice cream, McDonald's fries, alcohol, like high carbohydrate, right, high fat, and then other foods.
Yeah, and actually, yeah, we've done some attentional bias studies to look at when people are food deprived, and do we increase attentional bias to food away from alcohol? And we do get evidence for that.
Yeah.
So you got to make them really good and hungry to move them from alcohol to like a piece of chocolate cake and stuff, but it's movable. Because that was one of the other questions too, that the attentional bias work was always just focused on alcohol and a neutral beverage. And then once I started working with it, I said, well, I want to know if I give alcohol, then the motivation to drink, if the dose of alcohol is sufficient enough, that you should see less attentional bias. But they might still look at food. And in fact, they do that too. So if you feed people, they'll stop looking at the food pictures. If you give large doses of alcohol, they'll stop looking at the alcohol pictures, which is kind of nice. You've got the cues should matter. They're both consumable, but it's the type of consumption. Yeah. Yeah.
So I was thinking about the fact that this peak in E2 also happens around the time of ovulation.
Mm-hmm.
So thinking about, these are young adult women in your study are not on contraceptives. And one of the things we know is that alcohol can be associated with potentially risky or unprotected sex behaviors. So that might play a role too, when you add on top of that acute disinhibiting effects as well. So that might be one implication of this as well, from just sort of a prevention of either STIs or unwanted pregnancy concerns. What do you think about that?
Right. I think there's several papers that talk about the old sort of social biology of it. When mammals are ready to reproduce, right? It may be important for them to be more disinhibited and more risk taking. Now that doesn't necessarily mean that's what's happening with women, and so that's why I really don't talk about social biology of it. But that's how they talk about it in papers, right? And so at times like that, they might be more disinhibited. But then what's interesting for us though is that we see this in young women that aren't taking any type of contraceptive, but it's just the generalization of this to most of the samples not there, because there's usually some form of there's a hormonal type of contraceptive that's being widely used, and how that would just wipe out these effects, I would imagine. But that would be a whole other study. Yeah.
Thanks. There's a lot of interest in recovery these days, tons of interest in defining it and understanding it better. I wonder how attentional bias and disinhibition changes over time post abstinence.
Right.
You know, where is the attention of somebody who quit drinking because they had a severe drinking problem? They quit drinking last week. How about a month later? How about a year later? How about 2 years later?
Yeah.
I wonder if there is if you see, I would expect profound change.
Right. I agree. It's a great question. And I'm really surprised that people haven't followed up subjects that are in recovery over long periods of time and look for attentional bias to say wane over time.
We have the subjects in smart recovery. They come in first day. Actually, we have people who come in still drinking, say, I want to control drinking. And we've been running this program for 5 years. And we have people who came in and said, I'm going to control my drinking. Months later, they stopped. A year later, 2 years, 3 years, we still have that.
Right.
And I wonder what we would find.
Yeah.
We borrow your glasses.
Yeah, exactly. Right. I know.
Just kidding, but it seems like it'd be a really valuable way to understand the process of recovery.
Yeah. We sort of approached that idea a couple of times, but then we didn't really have the clinic structure like you have, Smart Recovery. We didn't have that that would work with us and do any type of long-term follow-up. That's
following up even further. It'd be really interesting to see what the influence would be of just entering our bar lab.
Yeah.
At different stages of change and what happens to people early on when they go into that environment versus later. Right. Because people after multiple years of abstinence, when they've really integrated kind of balance in their lives, they can have friends drinking all around them and they're not tempted. Right.
And so it might be a process of just habituation of whatever reactions were there, such as the heightened attention. Right. And then over time, it's just another stimulus. And that would be ideal. That would be the goal.
Yeah.
Right. Yeah. Well, very good question. Yeah.
Thank you. That's very exciting.
Sure.
The model that about with the examining inhibitory control, do you know if you would see effects among substances that don't have the same like intoxicating like cognitively impairing effects, like for example nicotine or foods?
Yeah, I've used this task with cocaine, with a wide range of cocaine doses, and cocaine's incredibly boring compared to alcohol. In fact, this is orally administered cocaine, and it kind of works in sort of an inverted U function. You get better inhibitory control with stimulants, and nicotine you'll get better inhibitory control too. And with cocaine and with amphetamine and with methamphetamine, I've studied those 3 drugs with it too. And I just keep coming back to alcohol because this makes sense to me. So yeah, caffeine as well.
Yeah.
High doses of caffeine. You can strengthen inhibitory control and tighten it up pretty good. Yeah. And of course, alcohol mixed with caffeine, like in Red Bull, like Michael and I were talking about. Yeah. You can sort of change things that way as well. So. Other questions?
Well, in your ADHD stuff, we always tested off medication.
Off medication, right?
So are you to that point? Have you tested on medication?
On medication? No, not to that. One of the problems too is that the medication history of these subjects, they're on various different types of medications too. So you'd have to take the ones that are sort of amphetamine based, the methylphenidates, and just test them. I think because other ones like Strattera and some other types of medications have very different mechanisms of action, and you might start bringing in a lot of noise. It's also interesting when young adults that are still taking medication, they still get their prescriptions filled, but they're very utilitarian about when they take the meds. So for them to go off medication to be in this study, not a big deal for them. They're usually off medications on the weekend. They might take their medication, start taking their medication a day before an exam. And then just go off again. So the consistency of it is difficult.
I think we'll stop there. For those of you that are coming to the training lunch, it'll be upstairs in the Cofrin Logan Center. If you didn't RSVP for the training lunch, you're more than welcome to come. I think we'll have a few extra box lunches, but a chance for some of our trainees to talk with Mark a little bit before he heads back to Kentucky. So thanks for making the trip out.
Well, thank you very much.
Yeah.
Said our drink was ever clean. I would have been.
Everybody's.
I know, right? Yeah, that's right.
Drink.
It's probably important that he knows it.
I'm not sure if you know if you're going the right way or
You're not gonna be worried.
Yeah.
Yeah.
Yeah, it's great talking with you too. Yeah, I like it. Yeah, thank you. Yeah, sure.
Yeah, great stuff. Yeah, I mean, it does make me think, all of these complex interactions between. Complex interactions between food and alcohol, and then there's got to be also really complex drug interactions
Yeah,
as well.
right.
With all these things, and then you throw birth control in there as well.
Yep.
And I think that. I have no idea. This is always the complex of this.
Mhm.
Is when we got these two screens. You know what? Somebody else figure it out. Just so we can log out this way.